let's turn to some of the questions from the viewers. One is, based on all of the data that have come in, what is your treatment of choice for the patients with 1 to 49% PD-L1?
So I'll give that patient chemotherapy plus immunotherapy. Based on where we are today, I don't think single-agent immunotherapy is appropriate for the majority of those patients.
Yeah, I will just highlight that the hazard ratio for that group of 1 to 49% on Keynote 42 was 0.9. So there was really no difference if you gave them chemo versus immunotherapy. And I think we see clear improvement in survival with Keynote 189 and with 407. So I think it would be a chemo triplet combination for me as well.
So again, just like, as I said, the comparator today in real world terms is not chemo alone. It's now chemo-immuno, and you do have a choice of a few different positive trial results, and I agree that histology-appropriate chemo-immunotherapy with pembrolizumab bubbles up at the top right now.
I would say, though, that I don't feel a total compulsion in the 0 to 49% group. I think it's still legitimate to do clinical trials guaranteeing exposure to these agents in a consolidation or maintenance strategy. I think that's actually consistent with the principles gleaned from this data. And for the patient with a relative but not absolute contraindication to the immunotherapy drugs, that patient where we may have a little bit more fear, but it's not going to totally stop us, I think it's legitimate to reserve the immunotherapy for second line.
Okay. Now, somebody asked also, does the actual agent matter? And my view is, we've talked about how they're more similar than different, but I would certainly be inclined to use the agent where the trial employed, do what the data show you, rather than just cavalierly presume they will be exactly the same. You agree then?
Yeah, I mean, I think the differences that we've seen between these agents reflect more the populations accrued and the way the trials were designed than structural differences between the antibodies. The classic example might be the Nivo-Pembro combination, where in lung, you could look at this data and argue that perhaps Pembro looks better, but in contrast, similar experiments in head and neck, you'd be arguing that Nivo looks better. I don't think there's a disease by drug interaction. I think you just have different patients, different comparators, different trial designs.
Somebody had we have a provocative question. We have data for squam and non-squam, but what about a patient with large cell neuroendocrine carcinoma? Would you use the 189 approach, or would you be inclined to use Pembro monotherapy? Would you be inclined to do a platinum and etoposide with Pembro, which I think would be my preference.
Yeah, I think this is faith-based medicine. We have very little data to guide us here, and I've always fallen, my religion for large cell neuroendocrine is that it's a non-squamous entity,
okay.
And so I give pemetrexed platinum, and now in this day and age I'll add pembrolizumab to it as well.
I feel the same way, especially if they're TTF1 positive. Then
okay.
I'm even more comfortable with the use of pemetrexed.
I would favor an etoposide-containing regimen for neuroendocrine histology still. I think there's no right or wrong answer here, but that would still be my preference.
And then the question of, what about a patient who progresses really rapidly within the first 4 months or so after chemoimmunotherapy? Mm-hmm. And that, are we really left with chemo, or are we left with docetaxel with or without ramucirumab? And there are some data from the REBEL trial that suggests that the patients with rapidly progressing disease may get a real benefit from ramucirumab. What would your approach to this kind of situation, which is not going to be rare? But
this is the patient who should go on a clinical trial. If you have rapid progression after a use of our most active agent, going back to the well and repeating cytotoxics, and thinking that you're going to have a high probability of response stands in contrast to the data that we already have. Ideally, that trial should be at UNC.
Yeah, right. I mean, that's the problem is, trials are always the right answer, but they aren't universally available.
And I will say that rapidly progressing patients are seldom good clinical trial candidates. I mean, those are the ones that are, in pain, their performance status is poor, or their labs are tanking. So I would say that our general gestalt for these patients at this day and age, at this time, would be docetaxel and ramucirumab if they're able to receive it.
Your thoughts?
I would use docetaxel, mostly just docetaxel.
Okay.
The only other thing I would add is that given the lower probability of cytotoxic response at this point, if you don't have a trial, you need to also be at least talking to the patient about hospice and making sure that further treatment with lower probability of response is consistent with their values.
So clinical trial or hospice, nothing in between.
Well, this is also...
Well, if they're not a good candidate, I'll send them to Penn.
We would also love to know whether it is true that patients may do better with chemo, even garden variety chemo after immunotherapy. That we need to get some actual data on, at least prospective data. So we could go on forever. This has been a great discussion, and there's going to be so much more to talk about in coming months. We'll have to do this again. So this has been a great discussion, and I hope you found the information valuable to you in clinical practice. Thank you for watching OncLive News Network.